We're now live, Chair.
Thank you, Kirsty. Thank you for your help and support there. So, good evening, members and guests, and welcome to the Adult Health and Social Care Scrutiny Board on Thursday, the 8th of December. On this very, very cold evening, so you'll be pleased we are actually on a Zoom meeting, so we can be nice and warm in our houses. So, hopefully not too warm, so we don't fall asleep. But let's proceed with the meeting itself. So, item number 1 is substitutes nominated for this meeting and apologies for absence. We've got no substitutes and no apologies, but I will hand over to Mark, who has an announcement to make.
Yes, Chair. So we have no apologies, but on the council on the 30th of November, it was formally agreed that Councillor Benton would be replacing Councillor Ford on this board going forward. Okay, thank you, Mark, for that. Item number 2 is members' interest, for members to declare an interest at the relevant time if they have any to declare. Item 3, admissions to the public. It's not recommended that the public be excluded from the meeting, so anyone joining us on YouTube, you are most welcome and hope you enjoy this meeting. Okay, so item number 4 is minutes for the Adults Health and Social Care Scrutiny meeting held on the 3rd of November 2022. I move those as a correct record. Do I have a seconder? Thank you, Councillor Bouchard. And can I move those to all members who were present? Thank you, members. So just before we get on to the main item of the agenda, I'd like to welcome Lauren Nichols from Brake, who would like to say a few words.
Hi, yeah, so my name is Lauren Nichols and I was diagnosed with a brain tumour when I was 18 months old. I had a brain tumour and I didn't realise it was a brain tumour. I was misdiagnosed by the GP as they thought it was a muscle imbalancement. So I just kind of came on your meeting today to kind of try and raise a little bit more of awareness and try and see from my perspective how it's quite hard having been diagnosed and then had a reoccurrence. So I was diagnosed in 2004 with a brain tumour called a pili-myxoid astrocytoma and had chemotherapy, should I say, sorry, and a 13-hour operation. And then I had a reoccurrence in 2007 and had an 11-hour operation and treated with radiotherapy. And the side effects from the brain tumour are affecting me now in the right hand side of my body, essentially, with my hand, my foot, and I have a visual impairment. And from my perspective, it's kind of raising awareness in getting GPs to know the key signs and symptoms. Because from my perspective, if my mum and dad constantly were like, there's something wrong, took me to the GP, and they were like, no, it's just a muscle imbalancement. If that was diagnosed sooner, I might not be affected by some of the things that I'm being affected by today. So yeah, just kind of wanted to raise awareness of that, really, and kind of especially for Councillor Howard to kind of actually put in £40 million into the brain tumour research. There's only been 10 million spent on that, and it's a 5-year plan. So what is it that's going to happen with the rest of the 30 million between now and 2023?
Thank you, Lauren, and thank you for you've clearly gone through an awful lot of trauma. So our thoughts are with you through that process and for highlighting your cause. I'm not the expert here to actually answer that question, so I'm going to look to one of the experts that might be able to provide you. But equally, we may need to come back to you with that with a timescale. I think on that one, I think it's. I don't think we've come. Nobody's come knowing about that question. So if it's okay, Lauren, if we come back to you with that information, I'm sure the experts will go away. In the meantime, if you've got some literature, are you involved in? Have you set up? Is it a charity that you've set up, or something on those lines, or?
Yeah, so I'm a young ambassador for brain tumour charity. So we do a lot of fundraising, obviously trying to find a cure for young people and adults and things like that. Yeah, so
So equally, if, Lauren, if you could send some information through, that'd be really helpful for members. You know, actually, we have a wide audience of people that we reach out to, and I'd certainly any condition in a young person is any condition anyone is severe, but especially for a young person. So so we'd love to spread that word on your behalf, and say we will come back to you in relation to the question that you've raised. I'll make sure that Mike and Bella follow that through, if that's okay.
Yeah, thank you.
No problems at all. Thank you for attending and highlighting that. You're more than welcome to stay for the whole meeting, but equally you may have other things to do.
Thank you.
Excellent. So if we go on to item number 5, so it's a winter planning. So I have a head of integration and partnerships, NHS. So this is a combination between Kath and Debbie, I think. Hi, Debbie. Welcome to the meeting. You're always welcome to our meetings.
Thank you. It's lovely to see you all. I am joined by some colleagues today on the call, and apologies in advance because I'm so unused to Zoom. We're all teamed out in the NHS, so apologies if any of this doesn't go quite as smoothly. So I'm joined. I'm just checking the list of who's in at the moment. So we have Michael Folan joining us from CHFT, Jane Sykes from Yorkshire Ambulance Service. We have Cass Gormley, who obviously is representing the local adult social care, and we may get Roland Miller on if he's not here already. Yes. Okay, so I think that Bella's going to enable me to share my screen. So we're going to see how this goes, and I think if not, Bella can rescue me, and she might pop the. So I'm going to see if this will.
It should be Mark that should be able to let you share your screen, but you should be able to share your screen. So
okay, let's just see. Okay. Bella, just let me know if that's happening.
That is happening, yes.
Right. Let me just check. I think is that okay for people as it is?
Yeah, whatever works for you, Debbie. We can see the slides, so
fantastic.
Other people can. So yeah, if you
fantastic.
Want to go through, yeah. I'm
going to just make that smaller just so you can see that. So thank you for asking us to come along. It's a really good time to probably do this. We feel, I think, as a system that we're probably in the middle of our the plans that we planned for, so in the middle of the circumstances. So just a little bit in terms of, I have several slides here. We're not intending to go through them, but what we wanted to do is what we did for members is submit a copy of our winter plan, which was submitted and agreed by NHS England, and a copy of our surge and escalation plan, which was also agreed by NHS England. We did that, I think, in about October time. So the slides that we circulated aim to give members a little bit more of a context that's more up to date, because things have changed. I'm just going to cover off the first 3 or 4 slides of the slides we prepared, because I think it'd be better to give members a chance to ask the questions that they have. So just a little bit of context. So we came to Scrutiny and found the presentation that we did Scrutiny on the 16th of December last year, and our update builds on that. So we continue this throughout the year. I think there's we have kind of we've come out of the pandemic to some extent, and we're going into winter, and it doesn't feel like pressure has eased in the way that it normally might do. We've prepared all the winter plans in the same way as we have done over the last few years. So we have an urgent and emergency care board that provides leadership and oversight. And we started our partner workshops preparing for winter back in August. As we said, the plans have been shared with members, so they have the detail. Just looking back at what we prepared last year, COVID was still a real key feature of our planning, and we had still COVID patients in ICU. Wherever we haven't got help, thankfully, patients in ICU from COVID at the moment, we are seeing obviously COVID numbers, flu numbers in our hospitals, and they're having an impact on their ability to ensure a flow of patients. And we've also had some funding from NHS England, which we've been able to use across our system to support our patients through winter. Just a little bit of context. We're using our strategic drivers as the inclusive economy strategies and also the wellbeing strategy. So focusing on that, the triangle that's in there, just that is aimed at really keeping people safe and well and supporting them as they go up in terms of need. We've got new chairs of our urgent and emergency care board. So we've got 2 GPs in the chair now. So the context is very much about system rather than just hospitals. And I think that's something that I know everybody's being keen to see the work as a whole system. We've got some new architecture. So we've got the Calderdale Cares Partnership Board that you're aware of, and the West Yorkshire ICB, of which I am a member, and we've got an NHS England new operating model. So lots of changes have gone on, and a lot of new expectations. So we've been given lots of things to deliver in terms of going further for winter, all sorts of metrics, 100-day discharges, all sorts of expectations that are coming down weekly. But what we're trying to do is we're staying true to the work that we do in Calderdale and the work that we do as a partnership. We've also developed our winter plan is very much aligned to the 6 months delivery plan that the Calderdale Care Partnership has in place at the moment. So we've tried to just make sure there's plenty of alignment. The other context really is that tridemic, which for winter, which is COVID, respiratory conditions, and a tough flu season. And I think if we were writing this today, we'd add into that the strep A. So we're all, I'm sure, aware of that. That's in our calls this week. It's very clear that that's having a huge, putting huge demands on all our services from both general practice right up to our hospitals and ambulance services. We know that the unprecedented cost of living crisis is making health, keeping well and healthy and warm very difficult for a lot of our families. We also know that we have a crisis of resilience within our voluntary and community sector, and we're trying really hard to engage them and to ensure that we can support them and that they can support us, because they have a huge role to play. You'll all be aware recruitment and retention is a challenge across all our system. And also we have through this year been continuing our transformation journey, and the ones to perhaps pick out are the urgent community response, virtual wards, and mental health transformation. What we've done in the slides that follow, which I'm not going to go through, is giving you some content update on a range of things: the community and voluntary sector, community services, so what we're doing in adult social care with our care homes and with home care. Some of those services that I've just mentioned, we've provided in the slides an update on mental health services and their challenges at the moment, ambulance services, 111 and other urgent care. We've also provided an update on our surge and escalation process, so members are really cited on those, and indeed the key risks that face as we go through winter. And we've also popped at the end some data which we thought members might be interested to see. This is 6 mandated metrics that NHS England are measuring us on, and they look particularly at things like bed capacity, bed occupancy, ambulance handovers, probably all the things that you would imagine. And so we've provided that data for you so that you can see where we are. I know we provided members with lots of information, and with your permission, Councillor Bradbury, I'll take down the slides and bring our colleagues in and allow members to ask questions.
Thank you very much, Debbie. That was extremely helpful, and the pack that you put together was extremely useful as well. It was very, very comprehensive and just right on the slides. So my type of style. You've been to my meeting before, so excellent. Right, so I'm looking for members in relation to raising questions. So I have Councillor Hutchinson. If they're not able to answer the questions now, they'll go away and come back. So Councillor Hutchinson first, please.
Yeah, thank you very much. A couple of questions, if I may, Chair. I would like to know more about the emergency community response teams, whether those are in place now in each of the primary care networks, and what level of staffing they have, whether they're fully staffed with these teams are supposed to be multidisciplinary, including occupational therapists, physiotherapists, district nurses, and social workers and paramedics, but they're not prescriptive, the description of these, and the idea is that they should be able to provide an assessment and try and provide care in the community within 2 hours of referral of a patient. So I was wondering what level of development those are at now within across Calderdale.
Thank you, Councillor Hutchinson. In terms of urgent community response, I'm going to ask Michael Folan from CHFT, who leads development of those teams in Calderdale, to come in for that question.
Okay, thanks, Debbie. Thanks, Councillor Hutchinson, for the question. So we're fully established now. So broadly, those roles that you've described, Colin, are in place. So we have nursing staff, therapy staff, social care staff. So it is, as you kind of allude to, a fully integrated team. So we've worked with CAF and colleagues in the local authority in terms of trying to make sure that if an individual has urgent needs in the community, we can assess those urgent health and care needs quickly, i.e. that 2 hours, but we can also support them for the next 2 to 3 days before we sort out the longer term packages of health and care. We're running 8 till 8, 7 days a week. There is an ambition in the system to turn that into a 24-hour model. So myself and Debbie and colleagues met this afternoon about some of the planning around that and how we're delivering that across the totality of Calderdale. There's a question mark about how we deliver it specific to the PCNs and the neighbourhoods, which we need to work on. But from a resourcing perspective, you can probably understand into how you split that team up 5 times presents its own challenges. But it's certainly an ambition from a system perspective to deliver that within the neighbourhoods and make sure we're integrated fully with those neighbourhoods. So I think it's a definite success story. There's definitely work to do to optimise that. So we're working with Jane and colleagues in Yaz in the Yorkshire Ambulance Service to make sure we can pick up some of the calls from the Yorkshire Ambulance Service rather than them coming into hospital, to then step them down quickly and to try and avoid unnecessary conveyancing and admission to hospital. So it's a success story. It's working very closely on that virtual ward piece, Colin. So the virtual ward and UCI should see as one function. So again, it's about that holistic service that covers all their needs in the community, because we know if you don't provide that holistic wraparound service, quite often they end up being admitted. So I think it's a success story. There's more to do, but it's working well, and we're more or less fully established. But it doesn't mean the ongoing challenges that Debbie alluded to in terms of recruitment and retention don't present as ongoing challenges. So we get fully established and we have somebody that leaves, because some of these roles, like the advanced clinical practitioners, Colin, who can do the kind of skill assessment. Yeah, they're in high demand. So primary care want them, local providers want them. So there's a lot of movement in the system around some of these colleagues, if that makes sense.
Have I got you right that what you're saying is that you've got one team that then is deployed across Calderdale? Because
that's right.
Calderdale's a long way, takes a long time to get along the Burnley Road. So having one team covering the whole patch must produce some logistical problems.
Yeah, we do. They are covering the whole patch. We do logistically, from a visits perspective, coordinate what goes on in the upper Calder Valley, what goes on in the lower Calder Valley. So it's not that they're all in central Halifax and they have to reach out. They're out on the road early doors in the morning, and we coordinate the contacts and visits according to locality, if that makes sense.
Yeah. Thanks, Michael. Another question I wondered was, as you flagged up, recruitment and retention of clinical staff is important, and we know that there are tensions in various staff groups across the NHS at the moment. I know that things like pay settlements are decided at a national level, but I wondered whether the Trust had actually considered discussions with staff as to other measures that could be brought in locally that might make a difference to people feeling that they're cared for, respected, valued. Things like, considering providing free public transport to and from work, free parking. I mean, particularly overnight and weekends when the car parks are otherwise empty. Creche facilities, in terms of supported creche facilities at work, and free food for staff during their shifts. So there's a number of things that could be considered that wouldn't necessarily have an impact on the bottom line pay levels. Are these things that have been explored?
Yeah, so definitely we look into a number of things. So the kind of food piece, we almost got a kind of not quite a food bank. I wouldn't describe a food bank on it, but we look at shall we share across teams, spare food. So there is work going on that. Staff health and wellbeing is a key strategy from a CHFT perspective. So we have a strong culture from a one culture of care perspective, and that plays out in terms of how we support health and wellbeing and how we work with partners on that. There's other things as well in terms of trying to make sure that we work with partners. So, whether it's with CAF and colleagues in the local authority or partners in locale and the community services in Kirklees, about how we make the roles attractive from a place perspective. So again, if I pick occupational therapists as an example, Colin, they classically work across local authorities, health, care more broadly. So how do we make sure that those roles are attractive and that we can keep them within our system, even if we're sharing them across providers? So there's a variety of things we're doing from a health and wellbeing perspective, and there's a variety of innovative approaches to recruitment and retention that trying to keep our good people in our system rather than lose them unnecessarily in terms of moving between primary care, local authority, health, etc. So there's a lot of work to do in terms of trying to make it an attractive place to work from a Calderdale perspective. And we have a session on, I think it's Monday, Kath and Debbie, in terms of looking at a Calderdale workforce perspective, how we work together to recruit, retain those individuals.
Okay, I would encourage some sort of fairly creative thoughts there. If you can I just ask one final question? Looking at the presentation that you sent out earlier on today, it showed that there's very high bed occupancy at Leeds Teaching Hospitals Trust, much more, even more than there is in Calderdale. And I just wondered whether that was having any impact on access to hyperacute stroke services and neurosurgery, where that has been centralised in Leeds, and at Bradford Teaching Hospitals on access to acute vascular surgery, which again has been localised. Are we finding that that's happening, or is that okay at the moment?
You want me to pick up, Debbie, as best I can? So we do provide hyperacute services in Calderdale, Colin, so we do have acute stroke services. There is, in terms of wider non-stroke neuro services, you're right, Leeds are one of the centres for that. And we haven't noticed any massive problems with that. Vascular services were moved to Bradford, as you know, and we have really clear pathways in terms of if patients need vascular surgery, whether that's elective or non-elective vascular surgery, we've got really clear pathways in terms of transferring to Bradford, and likewise, we haven't seen any issues with that. So with regards to Bradford and Leeds providing those two services, no major issues noted, but we do provide hyperacute stroke services in Calderdale.
Right, okay, thank you.
I would like to come in on that, I think. So Neil, would you like to?
Yeah, thank you, Chair. So it's just to sort of back up what was just said. So we aren't seeing an impact because of how busy Leeds is at the moment. However, that has been flagged as a risk in the coming weeks with the current strike actions, particularly with transfers and the ambulance strikes, which are due on the 20th and the 28th. So it is monitored on a West Yorkshire basis. We're not seeing any concerns around access for people for centralised services, but there will be risks and potential issues on strike actions in the coming weeks.
Thank you, Neil, for that. So, Councillor Kingston.
unmute myself. Thank you very much. Like Colin, I've got a few questions, some of which are just aimed at helping me to understand the things that I've read better, but some of which are probing into them. I'll start with the probing. The discharge imperative that it runs through a lot of this imperative to discharge people quickly, get them into a care or a home setting as quickly as possible in order to clearly to free up beds for new patients. I just wondered, what data do we have? Do you have access to for comparative purposes, so that as we implement earlier and earlier discharge policies, have we got data that we can compare against to make sure that that isn't creating adverse effects? Are there going to be adverse health consequences from discharging people more and more quickly? And how can we be sure that that isn't happening? Have we got like safety mechanisms in place that flag up actually we're seeing more people having strokes soon after discharge or things like that, or adverse heart events, various things like that? What safety mechanisms have we built in to make sure that these new policies don't have adverse effects?
Michael, do you want to come in on that side?
Yeah, I can do. So in terms of evidence, Councillor Kingston, we know, generally speaking, that the longer a patient is in a acute bed or community bed, and the longer the length of stay, the impact of deconditioning tends to have negative effects on outcomes. So we know, particularly for the frail and elderly population, that the longer they are in a bed, the more deconditioned they become, and the poorer their health and social care outcomes are in the longer term. So that's a large part about why we're really working hard to try and make sure that once they're medically fit for discharge, i.e. all their acute clinical needs are met, that we discharge them primarily to home. So we know, again, there's, between discharging into a care home bed, for example, or discharging home, likewise, you tend to have better outcomes if you discharge home, because from a functional perspective, from a psychosocial perspective, patients tend to recover better in their own home. That doesn't mean there aren't individuals who need bed-based care. So they may be medically fit for discharge, but need ongoing reablement or rehabilitation needs. And that's where some of the intermediate care beds, transitionary beds come in, that we need to do some work in those bedded environments. But the evidence is really clear, not just within the UK, but internationally, around the longer they stay in a bed when they've not got any ongoing medical needs, the poorer the outcomes. We have to keep an eye on, in terms of making sure, as you can have alluded to, that if they are stepping down early into some of the virtual ward, early supported discharge functions, that we keep an eye on incidence risks. But between health and social care, we have really clear governance around reporting against incidents, so we keep a track on those. So if there's any themes that are evolving, with stroke pathways, frailty pathways, cardiovascular pathways, we have really clear governance in terms of identifying what those themes are, and then if there's any actions associated with those themes, that we do take those actions as quickly as we can. But the evidence is strong, Councillor Dickinson, in terms of the earlier they can step down into their own home, the better the functional outcomes tend to be for the individual and their families, and then the longer term impacts in terms of, you tend to find they have less ongoing health and care needs. So the sustainability of health and care is partly dependent on being a bit smart with regards to that early supported discharge.
Great, that helps me understand something as well, because that sentence to treat delayed discharge as a potential harm event.
Absolutely,
I understand why that was happening, and you perfectly explained.
Yep.
Thank you very much. There was something somewhere in the report, and I'm sorry, I've got a lot of papers here. I read something about system versus sovereignty, and I didn't understand that, and I wondered if somebody could explain what was meant by system versus sovereignty. What specifically, what's sovereignty referring to?
Shall I pick that up? Don't know. Yeah, the notion was that we all work for sovereign organisations, so we all have a place at an organisation we call home. But actually, in the context of Winter and as a system as a whole, we work together. So we see the population of Calderdale, and obviously for CHFT slightly broader, as we're all accountable. We are all responsible for delivering urgent and emergency care services that do the best by our population. So I guess it's taking off our individual hats as organisations and any siloed thinking and coming together as a team, I guess, so hopefully.
That's great. That
Thank you.
Help me make sense of it, right? And then always I have acronyms that I struggle with. What's LOS?
Oh, it's length of stay.
Length of stay. Thank you so much.
Yeah, sorry about that. We have tried to.
I couldn't. I get
sorry
it.
about
that. Right, and then I read something about improved discharge to care homes. Clearly, there's an imperative to improve discharge to care homes. I think that was part of the Calderdale Cares partnership. That I read that in the context of Calderdale Cares partnership. And what is it that we are improving in discharge to care homes? What's that improvement? What improvement are we looking for? What are we looking to improve?
I'm going to bring my colleague Kath in, if that's okay at that point. I think this is probably Kath's.
Sorry, sorry, I thought I was still on mute. Yes, that's fine. So just to comment, previously I put my hand up and then put it down because it went out of sync, but just in terms of that sovereignty versus system, I think just to add to what Debbie said, it's about being really person-centred and about each of our organisations really prioritising the person and the community rather than our organisation. So it's really kind of being outward looking. I think there's a number of things around care homes and improving the discharge to care homes. So I think there's some quality issues with some of our care homes that we work very closely with, but we've also, in terms of what we call a trusted assessment. So when we're discharging somebody from hospital into a discharge to assess bed, so the person won't be very won't be known at all to the care home. It's about really making sure that they've got enough, as much information as possible on that person, on the circumstances, how to best manage the conditions of that person. And our social care brokerage team and our quality team, we have what are called business relationship managers who really link in with the care homes to make sure that we've got those good relationships. So if there's any issues around that trusted assessment, that the care home knows who to contact to kind of get that best information. And we've got those then planned reviews, and then our professionals kind of go into the care home to do that further assessment. So it's kind of improving that experience really for the person who's going into the care home, and also to support the care home with that discharge. Does that make sense?
It does. Thank you very much. That's me, Howard. Thank you.
Thank you very much, Councillor Kingston. And Councillor Barnes, please.
Thank you, Chair. So I was slightly late into the meeting, albeit I was listening intently on the 503 from Huddersfield. It wouldn't be a meeting if I didn't have some figures to have a go at, or have a look at, and try and get some data on. Slide 25, which is bed occupancy. My reading from that is that the figures from September, October, and November are substantially higher than the trajectory. And I presume that the baseline is just the average of what's been run in 2022. How do these figures compare to 2021? And at what level do they become unsustainable? Because at 97.6%, if that's what the figure was from November, would imply there's no fat.
In terms of data, we can find that data, but I think it is probably Michael who could give us an indication of how it feels like to be in a trust where the bed occupancy is at that kind of level. So I'll hand back to Michael.
So I think it's fair to say it's difficult. So I think not only we at high levels of occupancy, Councillor Barnes, we're also at high levels of capacity. So we've had to open up all the physical space literally that we have in the hospital. So we are meant to run at lower occupancy levels than that to give us enough capacity to support surges in demand. But I think it's fair to say where we are at the moment, we have this kind of escalation framework called OPAL. Now we've been normal times, you kind of sit in a kind of OPAL 1 and 2 level, but we've really been at OPAL 3 now for the best part of the last 12 months in essence, Debbie. So, and we did tip into OPAL 4 earlier this week. So we're running at high levels of occupancy and we're running at high levels of capacity. And I think that's a reflection of the pressures that Debbie alluded to in the system and some of the challenges that we have within community capacity in its broadest context. So there's a demand piece. So we know post-pandemic, the levels of attendances at A&E have increased significantly, so 20 to 30%. We know that patients who are presenting with higher levels of acuity and higher levels of deconditioning. So that then tends to lend itself to higher levels of admission. And if you can't then, as you know from national media, if there's challenges in terms of stepping them down into the community, then that does then put pressures on in terms of increasing capacity in the hospital and higher levels of occupancy associated with those beds. So it's challenging, I think it's fair to say, for everybody in the system.
Can I just
and I know Neil wants to come in, but at what level does it become unsustainable?
That's $1 million question. I think we're in a very challenging position. I think it's fair to say. I wouldn't like to say when and where, but I've worked in the NHS since 1994, and I can honestly say I've never known it as challenging as it is at the moment. But I think everybody in the system will probably agree.
Okay, I've got some follow-up, but I know Neil wants to come in, Chair, so if that's okay.
Yeah, no, super. So Neil, if you'd like to come in, then I'll come back to Councillor Barnes.
Yeah, thank you. So Mike, I know you like us to be specific about percentages regarding beds. Unfortunately, it isn't that scientific. So on a couple of those points, 21 data is probably going to be irrelevant. That's a COVID year, so it's probably not going to be comparison. However, private COVID hospitals would run between 85 and 93% occupancy. So we're running at 97.5. Leeds is running at 103. So we're at those already. When you're getting to the Leeds realm, which is over 100% occupancy, as Michael says, you're into either a major or critical incident, and we have to report that to NHS England, and that triggers all sorts of things like ambulance diversions, cancellation of surgery, and all those sort of things. So that is the next stage from OPAL 4. OPAL 4 has been declared on a couple of days this week, recognising and it's not just bed occupancy that's put into it, it's safe staffing levels. So it's the amount of nurses and healthcare assistants you have on wards, which there are indicators that the hospital look at it every day with regards to whether it's safe to open or maintain the current bed occupancies. So there isn't a definitive, you hit this figure and then it becomes unsafe. There are various factors that can be brought into place and lots of contingency plans about using different staff to do different things to help manage the risks.
Yeah, thank you. I think where I'm coming from is if you look at the higher levels of NHS 111 call abandonment, the pressures that are on GPs, the comments that people are presenting to A&E in a more acute condition than they were before. And this is not a criticism in any way, shape or form of anybody and anything in this situation, but it's obviously a trend there, isn't it? And then we have at the back end, when people are being discharged, and we've had this debate about the pressures that are on GPs and the continuing services. From a semi knowledgeable position that we are on this committee, these councillors are on this committee. We know you are concerned, and don't get me wrong, it's not about that, but you can see where I'm coming from.
Yes,
and I know you're aware of it, Neil, and I know you are. I'm not. That's not.
But on the sustainability bit, Mike, I don't think we're far off it. So pre-COVID, your right to reside or your discharge to set people ready for discharge, we got hauled to London for having 40 on that list. We're now running regularly over 100 on that list. So that is people that need to be in a different care setting, not a hospital setting. When you've only got a bed base of about 600 and you've got 100 with people ready to discharge in it, it takes a whole load of flow out for emergency admissions. So it just clogs it up. That's why the back end is sort of looked at as an important, and why social care, and we're working across the system to rectify it. But yeah, having over 100 across Kirklees and Calderdale ready to discharge, it creates huge ripples to the system and patient flow. So there are a number of hospitals, particularly in West Yorkshire and nationally, that are nearing that this isn't sustainable anymore unless something fundamentally happens.
Yeah, and I think as well, and I sit on the joint scrutiny committee with the hospital reconfiguration. You know, you look at the hospital reconfiguration plans, which are part of that, are predicated on the ability, you know, to that community services are going to cover some of that area, and it's just there's just the pressures are there, and it's, as I said, it's not a criticism of anybody in any way, shape, or form. And I know that, you know, Neil, that the fact that you've answered the questions and the data you have, I know you're aware of it, but you can see where we have to come from as councillors. So thank you, Chair. Thank you, Neil.
Yeah, thank you.
And thank you, Michael. Sorry, that was rude of me. Apologies, no, Michael.
It's okay. Councillor Kingston, please.
Thank you. I missed out a question earlier. It was about the objective for 0 12-hour emergency department delays. I just wondered, has there been any progress on that? Is that better or worse?
I think Neil's going to answer that one, hopefully.
So that is always an aspirational target, and I'd say this week it's been failed. The strep A issues that sort of escalated from Friday onwards meant significant delays in hospital. Now, they were kept to a minimum, but I would say prior to sort of the unexpected that's happened across all the NHS in this last week and the media coverage, CHFT were good performers on that. It was 0. So 12-hour waits in A&E is prided upon at CHFT. We're one of the top performers in the UK, but you can't always bank on announcements and situations like have occurred. It is sort of getting back to normal this week, but particularly the weekend and the beginning part of this week, there were some 12-hour delays. But when you get surges of 30 to 40% above what you normally see, it's hard to maintain some of those standards.
And just something from this, I was at a separate committee meeting this morning with some councillors from other councils, and I learned, I think it was in Kirklees, that they've had 8 child deaths from RSV, is it, in the last 4 to 5 weeks? I wondered, are there alarm bells ringing? Is there, as well as this strep A, is there something else going on?
Michael might come in on that, hopefully.
Yeah, so the RSV is almost the kind of winter virus in terms of respiratory infection for young children. Councillor Kingston, it is seasonal, so it does happen every year. You do, a bit like the flu season, you do have variations in those seasons. I can't speak specifically for the number of deaths, but I will potentially take an action just to do some investigation in terms of how many deaths we've had with regards to RSV. But we definitely have plans within CHFT, but it's also a system plan around children and paediatrics in terms of RSV. So I'll come back with some details on that, Councillor Kingston.
Thank you, Michael.
Graduates though, so it's not really my field, but yeah, I was just fascinated by that, and I will, yeah.
Thank you, Councillor Kingston. Councillor. Yep, thank you. Councillor Hutchinson, please.
Thank you, Chair. The £500 million that the government has announced quite a long time ago that they were going to be providing to reduce some of the winter pressures, I believe has now at last been released for use. They talk about it increasing ambulance usage and easing pressure in A&E, but from my understanding, it's that money, a lot of that money would be much better spent in expanding social care and out of hospital care, so that these people who are languishing in hospital can be discharged. What have we got that yet in Calderdale, and is it being used for that, or how are we actually making use of it? Do we have the ability to actually recruit people to expand home care services apart from anything else?
Neil, would you like to come back on what you've indicated?
I'll kick off, but Kath might want to come in as well. So yes, the £500 million is starting to filter through. Calderdale, I think, are beneficiaries of about £2 million of that, because it was split into two, directly for local authorities and for healthcare. And it has sort of been decided that social care is the area that needs to be. So plans, I presume, are, and Kath will probably expand more on this, used to enhance social care. So the local authority will be receiving this money.
Kath, would you like to come in on that as well? Yeah.
Yes, thanks, Councillor Bladbury. So, so you will know from the autumn statement that the adult social care reforms have been paused and delayed for 2 years, but the additional funding that was proposed has they've still committed to that. So we're still working through. So I can't give you any kind of figures at the moment, but we're still working through the guidance and the actual allocations of that. And looking at how we take forward those proposals in terms of supporting our care market across care homes and home care. So that obviously workforce is a really big issue. So looking at what we can do in terms of fee uplifts to support the aspiration to look at real living wage and make sure that kind of is filtered through to frontline workers. We've got a number of initiatives already ongoing. So the Calderdale Cares careers website is up and running, and that's really pushing on kind of big adverts for a career in how to get careers in social care. So that's for frontline care workers, but also social workers as well. So there's a number of things in play to kind of strengthen the market, stabilize the market, and make sure that we've got a good offer, and that we kind of build on what we've got.
Thank you, Kath. Colin, do you?
Yeah, I mean, an integral part of this flow through is obviously discharge to assess process. But 2 years ago, Healthwatch and the Red Cross published a report into the reality of discharge to assess, where they found that 85% of people who were being discharged weren't getting assessed. And that in about 20% of them, when those assessments, if those assessments were made, it revealed additional needs that weren't identified, and that a third of the people who were discharged didn't have a contact details of anyone to get in touch with if they were running into problems. I would like to know how assured we can be that discharge to assess is actually following through on the people who are discharged, and we're not just storing ourselves up problems with sort of short scale readmissions because care hasn't actually taken place.
So would you like me to come back in on that? Sorry. So that's what I was saying before. So in terms of, we've got a number of things. So if people are discharged to assess into their own home, often they're followed up by our reablement teams. And again, it is, as Michael was pointing out before, it is actually much better to be assessed in your own home than it is in hospital, because it's an artificial environment for people. And often we will put in a package of care from reablement, and then actually the person might need a lower level of care because they're back in their own environment. They're assessed by an occupational therapist. They can have assistive technology and equipment, etc. So and those resources and those reviews are taking place. I can certainly take an action away to make sure that we've got the data and that we've got that absolute assurance that there's no issues with that.
Okay, that would be really helpful because it's just left as a question that's hanging. one final comment. Before the winter before the pandemic, these kind of pressures were there then. And we received the Urgent and Emergency Care Board provided elected members with a weekly SITREP situation report, so that we knew whether we could then put any problems that our constituents were experiencing into the right sort of context. So, because sometimes the flow of information is not terribly quick. Can I ask whether it would be possible for us to resume that practice that ran through the 2019-20 winter?
Neil, you're going to, Debbie, it looks like she's going to respond to that.
So, we have, well, not clear what the data looked like that was received, Colin. It'd be good if it's possible for you to identify what that is.
I can send you a couple of examples.
Yeah, I think it was probably possibly, I don't know if it's COVID related or pre-COVID, but
it was pre-COVID.
Okay. We'll certainly have a look at what was provided previously.
Thank you.
Thank you, Councillor Josh Fenton-Glynn.
Yeah, just to comment just a couple of things that Colin raised. And by the way, that's a lovely Christmas jumper you're wearing, Colin. I think we all need to take a moment to recognise that. It's Christmas Day today, isn't it? Sorry, back to Buzz. I think one of the things that kind of, from my point of view, seeing as kind of as cabinet portfolio holder, I find sometimes a bit kind of galling when you get these big government announcements of lots of money. I mean, firstly, actually, when you share 500 million up to between 300 upper tier authorities, it's not actually a huge amount of money, although it's it's not a number to be sniffed at. So in reality, it's a couple of £1 million here and there, which is helpful to what we're doing. But actually, the pipeline for care does have to be a bit longer than that, and that's why we've been working in a kind of consistent way on workforce. So, earlier in the year, we did have the papers committing us to work towards a living wage. And as Kath mentioned, the Calderdale Care Careers website, which actually at some point it'd be great if you guys could take a look at, because it's a really excellent piece of work and something that we're really proud of. That actually, not only does it show people what care careers look like, but also it talks about, kind of some of the offers and the kind of upskilling opportunities in care. So actually, a bit of time on that work and development. Kind of, I just want to quickly pay tribute to the work that's been done on that. Is quite important. The other thing I'd say is you talked about the kind of discharge to assess work. I think probably that's one of the things that's got better as work's got a bit closer with the ICB. These things aren't perfect, and our reablement team are doing a good job. We're currently in the process of looking at how our reablement team works to make it as effective as it can be. And we also were looking at doing some work with one of our care providers, Welcome, to make sure that when we put in place the care providers, we also make sure that they have the expertise and the knowledge to deliver good care, kind of once the kind of assessments have been made. But again, like the reablement team is something that but as we get through this current look at the team, it might be something that's worth you guys having a look at a bit further, because some of their work is really brilliant, and I think there's always good opportunities to look at what we're doing well around here as well.
Thank you, Councillor Fenton-Glynn. I think Michael's going to respond to that.
It's just really to support the importance of reablement, and I think Kath alluded to it, that part of the trick here is shifting the discharge to assess model to a discharge to assess home first and reablement model. So I think that's what helps us have a more sustainable system moving forward. And there's plenty of good evidence. It's worth looking at the kind of Canterbury model from New Zealand, that they focus very much on that reablement and rehabilitation offer and that home first principle. And I think that's the trick, isn't it, Kath and Debbie, in terms of the next few years about how we move some of that pandemic-based discharge to assess process to a genuine discharge to assess and home first and reablement model.
Absolutely, definitely.
Yeah, super. Thank you for that. I think one of my fears, and which puts greater pressure, is actually the ability of heating and food, because I think that's going to put greater pressure on the service, and I think it's a real key. I think the other one as well is people just needing on the counter prescriptions. And I know my partner suffers from asthma, and she wanted some ibuprofen. So she asked the pharmacist to if she could have some. He said, "Oh, you take it. Have you got any other conditions?" And she said, "Well, yeah, I've got asthma, and a condition that she's managed for quite a number of years, and therefore he sent her away because he wouldn't serve her." So actually, things like that, I think we need to be working in conjunction and making sure that actually, asking some additional questions with the pharmacist, saying actually, okay, how do you manage your condition? Because actually that, in essence, she went somewhere else, but actually it could have meant going to a GP or putting additional pressure on. So a few different things there. I think Calderdale have been really excellent in relation to sending out a brochure recently about Ready for Winter. I don't know what it's called. It's really, I've seen it, I've looked for it, and it's really, really useful information, but I don't know what the title was, so my apologies. So very much appreciate the comprehensive report and the answers and the questions as well. Kath, do you have anything else to add from the council's perspective?
No, I don't think so. I think in my short time of being here, I've been really heartened by the amount of partnership working, and adult social care definitely works really closely with our health colleagues in as seamless a way as possible. And I know that we're continuing to build on that as a system. So I think we've got a strong system with good relationships, which is a really, really good foundation. So no, thank you.
No, super. Well, certainly, our thoughts are with the service. We appreciate there's a great deal of pressure on the service, a great deal of additional demands. So our thoughts are with you, especially in this period, a very, very challenging period. And we're not going to say anything other than that. So very, very much thank you for attending tonight and presenting and preparing, and not giving us death by PowerPoint. That was really useful, but giving us the slides. So that's really helpful. So thank you for that, and thank you for attending this item. So you can, I know you have other pressing things to do, so if you need to go, I wouldn't be offended. As we move on to item number 6, a detailed review into general practice, and this is Mike is going to come in on this. Mike Lodge.
Thank you, Chair, and I suppose for the benefit of those listening who haven't been involved, this is a piece of work that's already been done by the Scrutiny Board in the session a few months ago. And the first thing I'd like to do is to thank all the people from the council and the NHS and other places who came and gave up their time and gave really helpful and powerful messages about what's happening in the system at the moment. So the reason for bringing the report is for it to be published in the public domain. The seminar you had was in private session. To ask the Scrutiny Board to adopt the report and its recommendations. We did send out draft report to all members of the Scrutiny Board, and I'd like to thank you for your comments back. They were really helpful, and I think they sharpened up what myself and Bella had prepared significantly. We also sent a draft to Debbie Robinson, who in the ICB, who was very helpful as well, and I'd like to thank Debbie for that, and helped us correct some of the sort of bits where we had lack of clarity and inaccuracies, and she did an admirable job at resisting trying to change things she might have disagreed with, but were the views of the board. So thank you very much for that, Debbie. I know that's often a challenge when you get a draft report. When we do bits of work like this on other areas of service, we normally suggest that you refer them to the council's cabinet when we do a detailed review. In this instance, I wonder whether it's perhaps more appropriate to refer to the work to the Calderdale Cares Partnership Board, where the council are as well as NHS colleagues and voluntary sector and so on. But that would be, if you like, a more a more relevant body in a sense than Cabinet, or you could send it to both, but I'm not quite sure what Cabinet would do with it, to be honest. So there wasn't anything else I wanted to add, Councillor Bradford, to the report. As I say, you know, the work has been done. This isn't starting a debate. This is wrapping it up.
Super. Thank you for that, Mike. I think we've proved that we do some very comprehensive reviews and ask some very challenging questions, and we are the critical friend. I think it's great reports. I suggest, I recommend to the board that we send it to the Calderdale Cares and copy in the Cabinet for their information as well. So I think I'm happy to move that. Do I have a seconder for that? Yeah, Councillor Hutchinson there. All those in favour? Yeah, super. Thank you for that, and then thank you all. Thanks to the officers in the background and the other agencies. It just shows this is a great scrutiny that we work together for the benefit of people out there and for the whole of Calderdale. So it's a great piece of work. So item number 7 in that case is the work programme for 2022-23. What's left of it? Mike, do you want to show again? And you're on mute as well, I'm afraid.
It is partly my show, Chair, but also for members to ask for items to be included on the agenda. When we've perhaps looked at the work programme, I just would like to say, spend a minute updating members on the work of the Buying Our Care working party that met yesterday evening. Not to go into the detail of the discussions, because that will come to a later date, but just to give an update for people on that.
Superb, yes, yeah, that'd be great. This on the meeting yesterday. Sorry, I think Mike's just frozen.
Sorry. What's your question, Councillor Blackburn?
I'm sorry. Are you going to provide that update? Sorry, is it?
I can do that. I mean, members will remember that you established a joint working party with Children and Young People Scrutiny Board to look at the implications of the report produced by Equal Care called Buying Our Care, which was about the commissioning of care services. There has been a planning meeting of members a couple of weeks ago, and the first meeting yesterday evening of evidence receiving, if that's the right phrase, for members, which was a long and full meeting, and in fact has been adjourned and will be reconvening later. And the members of the working party also decided they wanted to have another planning meeting, perhaps to look at their schedule and work programme, how that should be amended in the light of yesterday evening's meeting. So that's really just to let people know that this work has started. It's going to be a challenging and detailed piece of work, and aims to report back to this scrutiny board, probably at an additional meeting with one agenda item in February. That's all. I think that's all. But the detail of what was discussed will come out later on.
Yes, thank you, Mike. Actually, Councillor Evans, who normally chairs the meeting, was on Zoom, so he left me to, and in the end, because the quality wasn't very good, so it was a challenging meeting, to say the least. But that was great. Right, well, we've come to the end of the agenda, so I'd like to wish you all a happy Christmas. It seems a bit too early, but it's only a fortnight away, I suppose. Very much thank you for all your support throughout the whole year. And thank you for your attendance this evening and the questions. And do you have a few minutes to just stay on the Zoom?